Good afternoon, everyone. This is Anastasia Harapal-Yap from our NAO Home Office, and I'm joined today with Tim Lenartovich, the Director of Nursing and Health Policy at Home Office, as well as RNAO's President, Carol Timmings.
Good afternoon, everyone.
So just some housekeeping for the webinar. The webinar will start off with about a 30-minute formal presentation, our Mind the Safety Gap report, and then we'll have a question and answer period. And due to the large amount of registrants we've had for this webinar series, we will actually be muting the teleconference lines, and we ask that you send us your questions to the WebEx chat box feature that's located in the lower right corner of the screen. This webinar is also being recorded so that it can be posted on RNAO's Mind the Safety Gap webpage to enable our colleagues who are unavailable to join live the opportunity to listen to the discussion that we have. And so I'm going to mute the teleconference lines and then pass it over to RNAO's President Carol Timmings for opening remarks.
The conference has been muted.
Carol, are you there? Carol, are you available?
I'm here now. I was just having a recording before, yeah.
Fantastic. Well, Carol, Anastasia had just finished doing some introductions, and over to you.
All right. Well, good afternoon, everyone, and thank you for joining the webinar. My name is Carol Timmings, and I am the president of RNAO, and I'm so pleased to welcome you to explore and learn more about RNAO's important policy report called Mind the Safety Gap in Health System Transformation, Reclaiming the Role of the RN. Now, just by way of history, you may recall that at RNAO's 2015 annual general meeting, we had announced that we would begin work to address the concerning trends that were occurring in Ontario's nursing workforce. And so we spent a little over a year analyzing health system priorities from the Patient First initiative and juxtaposing them with trends in nursing human resources, population health, and evidence on nursing skill mix and organizational models of nursing care delivery. Now, our findings were quite shocking, and regrettably, that trend has certainly continued. So as we move through this webinar, Tim and Anastasia will be sharing in greater detail the findings of the report, as well as recommendations that RNAO has issued to position the nursing workforce in a direction that truly puts patients first. Now, the Minister of Health and Long-Term Care recently tabled bold legislation to begin the implementation of his plans for health system transformation. And this bill draws upon the plans outlined in the 3 Patients First documents that were released back in 2015. So as discussions regarding this bill advance, we believe that this policy report can be used as a tool to in fact refine or to inform the refinement and implementation of the legislation and ultimately the vision laid out in Patients First. So I encourage and welcome all of you to become involved in this very important policy process. And I will also commit that RNAO will continue to be at the forefront of influencing and guiding systems change. So thank you for the opportunity just to share my introductory remarks, and I'll now hand it back over to Tim and Anastasia to begin the presentation.
Thank you very much, Carol.
My pleasure.
And so to begin the presentation, I'd like to start by sharing the current state of the nursing workforce in Ontario. The largest share of the workforce is registered nurses at 96,000. And according to regulation, RNs can care for any client, including those that have complex needs, are less predictable and are being cared for in unstable environments. We also have about 39,000 registered practical nurses who are prepared to care for clients that are less complex, are more predictable, and are being cared within stable environments. 2,400 nurse practitioners complete the nursing workforce in Ontario, and they build and expand on RN competencies within their specialties. And their duties may include being clients' most responsible provider, as well as attending roles in long-term care, to name a few. All nurses have an important role to play in the healthcare system, with appropriate utilization being key. And so RNAO regularly monitors nursing human resource numbers and trends by analyzing data from the College of Nurses of Ontario. And of concern, the share of RNs across sectors has significantly decreased, with the exception of public health, where nurses are legislatively required, or where RNs are legislatively required to be public health nurses. And this trend has been confirmed by the latest statistics from the Canadian Institute for Health Information, which now places Ontario with the worst RN to population ratio in Canada. So the current policy agenda is about redesigning the health system around the needs of Ontarians, with the objectives of optimizing quality, outcomes, and returns on investment. And the government has proposed doing this by shifting care to the community, which is actually where people want to receive their care. And this shift in the community is occurring at a time when demographics are changing, patients have more complex health needs, and technology is changing the way that we provide care. And this shift is not just a shift in where services are being provided. It's reflective of a broader shift from an illness-focused health system to one that addresses health holistically and also supports wellness. And as the health system makes this shift, it means hospitalizations will be shorter, patients in acute care will be more complex, and then they'll be discharged earlier to communities and long-term care with more complex needs. This shift is also occurring at a time when the RN scope of practice is expanding to include independent RN prescribing, as announced by the Minister of Health and Long-Term Care at RNAO's 2016 AGM. And the NP scope of practice will also be enhanced, as well as public health and primary care, to meet the objectives of the current policy agenda. So while RNAO supports the current policy agenda for health system transformation, which has in fact been strongly influenced by our ECHO report, we are concerned that no provincial interprofessional health human resource plan has been developed to actually fuel these changes. So what we need to be asking is, what are the trends in population health needs? Where is the health system going? And how will the demand for health human resources across sectors in terms of supply, distribution, and utilization change in parallel? So it's no secret that organizations are facing budgetary constraints and that nursing is a large operational cost, erroneously considered by some as low-hanging fruit for cost saving. So some organizations are making changes to nursing skill mix and organizational models of nursing care to meet their bottom lines today. But this has a significant impact on the workforce's overall capacity to respond to the system transformation efforts that are being implemented. So to achieve the patient's first vision, and as Carol alluded to, legislation has already been tabled to begin its implementation. It's making it critical that decision-making be driven by evidence, quality, safety, and optimal patient outcomes, not by budgetary constraints. So we've all seen a wave of headlines identifying organizations that are replacing RNs with less qualified providers. And whenever RNAO receives concerns from members or sees these types of headlines in the media, we always connect with the chief nursing executive at those organizations. We want to ensure our understanding of the situation is accurate, and if we have safety concerns, we do have an obligation as an association grounded in evidence to speak out, which we have done and which we will continue to do. And so although this slide highlights what our NAO has done in response to RN replacement, it really reflects what you, our membership, has done. We have to give a big thank you to all of our members that have responded to our 2 action alerts to stop RN replacement and implement the recommendations from the Mind the Safety Gap report. And we've had over 21,000 respondents to those 2 action alerts. Our members have also participated in our 2016 Queen's Park Day and our 2016 Take Your MPP to Work events, where nursing HR issues were key priorities. Our members have been active on social media by tweeting and sharing about these issues, and they've also participated in the dissemination of the Mind the Safety Gap report. So now I would like to present RNAO's model for health system effectiveness. There are 4 pillars necessary to achieve the optimal health outcomes that result in health system effectiveness: evidence-based policy and practice, full and expanded scope of practice utilization, interprofessional practice, and health human resource planning, which is the focus of this current report. So in the Mind the Safety Gap report, we conducted a 10-year trends analysis of nursing workforce data, an analysis of population health needs, a historical overview of nursing models of care delivery, and an analysis of health system priorities. And our aim was to understand what population health needs are in Ontario, where the Ministry of Health and Long-Term Care would like to go, and how nursing either aligns or disconnects with these health system priorities. And what we found was the current trends within the nursing workforce do not align with where the health system is going. And so we reissued an urgent call for an interprofessional health human resource plan for Ontario that would follow a transparent, evidence-based, and engaged process. So for the report, we did a thematic analysis of the 3 Patients First documents that were released by the Ministry of Health and Long-Term Care in 2015. And we identified priorities by identifying the key themes that were consistently presented in all 3 reports. And these included reorienting the health system within community-based care, increasing public transparency, providing coordinated and integrated services that match population health needs, and monitoring health system performance and improving accountability. And for a more detailed explanation of how we arrived at these themes, please refer to Appendix A in the report. So we see 4 key nursing priorities as contributing to the 4 policy priorities identified by the Ministry of Health and Long-Term Care. And this report will focus on the first 2. So appropriate nursing skill mix utilization is about ensuring that the skill mix distribution aligns with patient needs and the knowledge, competencies, and skills of the different categories of nurses. We also see organizational models of nursing care delivery that advance continuity of care and care provider as crucial to achieving the policy priorities. Maximizing and expanding scopes of practice and evidence-based practice are also key, but they've been addressed extensively in RNAO's other work through our International Affairs and Best Practice Guidelines Department, as well as our policy submissions to organizations like the Health Professions Regulatory Advisory Council. So they're not covered in this report specifically. So this slide refers back to the broader shift the health system is undergoing from a reactive, illness-focused health system to one that is proactive and addresses health and wellness holistically. And in order for this shift to happen, we need a health system that includes robust public health services, including public health nurses, coordinated primary care, social and environmental determinants of health, and health equity. And we see effective scale mix and organizational models of nursing care delivery as facilitators to this shift. So due to this over-reliance on an illness-focused health system historically, patient complexity is increasing. And in the past, despite the incredible efforts of public health, there has not been enough support at a systems level to address the social and environmental determinants of health, resulting in a population with chronic diseases, comorbidities, and complex needs. And although the complexity of care is increasing, the share of RNs in the workforce who can safely care for complex patients has decreased. While the share of the RPN workforce rose from 21.5% to 28.4% from 2005 to 2015, Ontario became the province in Canada with the lowest RN to population ratio. And so Ontario currently has 711 RNs per 100,000 Ontarians versus the Canadian average of 841 RNs per 100,000 people. For the report, we also conducted a literature review to synthesize the evidence on nursing skill mix, as well as organizational care models. And so while we did include evidence from researchers in Ontario, the scope of our search was international. We looked at other developed nations and pulled the best literature from experts in the field. And the evidence is very clear. Replacing RNs with less qualified providers results in increased mortality, readmissions, adverse events, lengths of stay, and transfers of care. It's also associated with a decrease in continuity of care, quality, safety, and satisfaction. And this slide addresses organizational models of care delivery, or more specifically, how the different categories of nurses are utilized in care provision. In primary or total patient care models, one nurse cares for a small group of patients, and the appropriate nurse is matched to the client's complexity, predictability, and stability. Conversely, in functional or team-based models, patient care is divided amongst the team and parceled out to a group of care providers. And as organizations shift from models of total patient care to functional or team models, continuity, efficiency, safety, quality, and patient satisfaction is lost. Our NAO sees primary nursing as the model that is best aligned with continuity of care and care provider. And this is where individual patients are assigned to the most appropriate nurse, whether that be an RN or RPN, who acts as their primary nurse throughout the entire care process, providing all aspects of nursing care. And this model of primary nursing differs from models of total patient care because efforts are made to ensure that the same nurse is providing care to the same group of patients over different shifts. And the evidence on models of nursing care delivery is also very clear. Over the past few decades in Ontario, our models of care delivery have endured turbulent cycles switching between primary care models and functional or team-based models. But when we actually look at the evidence on these functional or team-based models, they result in increased hospital-acquired infections, more time spent in administrative tasks, they increase the fragmentation of units and create hierarchies within care teams, They can also result in inequitable workloads, an increased risk of liability, and increased adverse events. They also result in less psychosocial care. The accountability becomes unclear between care providers, that continuity of care and care provider is lost, and productivity actually decreases. And so now that we have gone through the key findings of the report, I will move on to the recommendations that our NAO has issued as a result. And so the first recommendation is that the Ministry of Health and Long-Term Care develop a provincial evidence-based interprofessional health human resource plan to align population health needs and the full and expanded scopes of practice of all regulated health professions with system priorities. And we see the Mind the Safety Gap report as the first installment of this plan with its focus on nursing human resources. And our second recommendation really ties in with the first. It's that the Ministry of Health and Long-Term Care and the LHINs issue a moratorium on nursing skill mix changes until this comprehensive interprofessional HHR plan is completed. We also ask that the LHINs mandate the use of organizational models of care delivery that advance care continuity and avoid fragmentation. Our fourth recommendation is that the Ministry of Health and Long-Term Care legislate an all-RN nursing workforce in acute care effective within 2 years for tertiary, quaternary, and cancer centers. And under the Public Health Act, or Public Hospitals Act regulations, we've derived these categorizations. So Group A hospitals are general or teaching hospitals. Group D hospitals are cancer care hospitals. And we've asked that within 5 years, an all-RN workforce be in community hospitals, which are Group B and are over 100 beds. And we see RNs working together with an increased number of NPs and clinical nurse specialists working within these centers as well. Our fifth recommendation is that LHINs require all first home health care visits to be completed by an RN. And after this initial assessment, that RN could determine care can be safely provided by an RPN or a PSW. However, it's essential that that very first visit be done by an RN. Our sixth recommendation is that the Ministry of Health and Long-Term Care, LHINs, and employers eliminate all barriers and enable NPs to practice the full scope, including prescribing controlled substances, acting as the most responsible provider in all sectors, implementing their legislative authority to admit, treat, transfer, and discharge hospital inpatients, and utilizing fully the NP anesthesia role, inclusive of intraoperative care. Our seventh recommendation has really developed to address the rising complexity of care in the long-term care sector. And so we're asking that the Ministry of Health and Long-Term Care legislate minimum staffing standards in long-term care homes, which includes having 1 attending NP per 120 residents, 20% of the staff should be RNs, 25% should be RPNs, and 55% should be personal support workers. And these are minimum staffing standards. And our final recommendation is to have the LHINs locate the 3,500 CCAC care coordinators within primary care to provide health system care coordination and navigation, which are core functions of the interprofessional primary care. So thank you all for participating in the formal part of today's webinar, and I encourage you to visit rnao.ca/mindthesafetygap for a copy of the full report as well as other materials that we've developed related to this work. If you have any questions, you can always contact RNAO's CEO, Dr. Doris Grinspan, and her email is provided on the slide, as well as the Director of Nursing and Health Policy, Tim Lenartowicz, whose contact information is also provided. So now that the formal part of the presentation is over, We're happy to take any questions that you may have. And again, we ask that you type the questions into the chat box feature in the lower right corner of the WebEx screen.
Great. Thanks, Anastasia. Just to add to what Anastasia has presented in a very excellent and comprehensive overview, you may be wondering ways in which you can get involved, and certainly we welcome your involvement by signing the action alert. Now, you may think that you've already signed the action alert, but ensure that you've signed the Phase 2 action alert. We did issue an action alert in 2015 regarding stop RN replacement, and the second action alert that we released, it was in follow-up to the Mind the Safety Gap report and is calling for the implementation of those recommendations. And if you've signed both, by all means, continue to share with friends, colleagues, coworkers, etc. As well, you're encouraged and welcome to contribute to the discussion that's underway on social media. So we currently have hashtag #MindTheSafetyGap as well as hashtag #StopRNReplacement. They're actively being used. As well, we encourage you to participate in various RNAO-led initiatives, whether it be at the chapter level, interest group, or being led by home office here. Your participation on today's webinar certainly shows you're well on your way. For colleagues who were unable to attend today, they're most welcome to review the archive webcast, which will be several of them are already uploaded, and we will upload this one a few days following today. And also, I think being champions of this work within workplaces and contributing to the broader policy discussion are all excellent ways in which you can help us to advance this important work. So I just wanted to add that, again, to the excellent presentation that Anastasia has provided, and we are standing by and looking forward to your questions. Okay, so seeing no questions, I think we've had something come through here. One moment, please. Great, so I think someone has asked us to expand more around RNs within primary care. And so one of the well, first let me maybe take a step back and recognize that primary care, a high-functioning primary care setting is the hallmark of a high-performing health system. And so for many years, RNAO, we've been relentless in our pursuit of building capacity within primary care and really seeing the roles of registered nurses and nurse practitioners as being central to achieving that goal within the context of interprofessional primary health care delivery. And so within the Mind the Safety Gap report, we do include a recommendation specifically about locating care coordination and care coordinators, approximately 3,000 of whom are RNs within primary care, to join the already 4,000 plus RNs who are already in primary care, and looking really at full scope of practice, and then also as well as expanded scope of practice utilization. And given that Mr. Hoskins had announced at our Queen's Park Day last month his intention to move forward with independent RN prescribing, I think this is a really exciting opportunity for RNs across the system, but especially as well within the primary health care setting. And so I think that the sky is the limit for RNs and NPs in primary care, and really looking at ways in which we can support the profession to work to its full scope within that setting. So any other questions?
And just to add to Tim's response, we also have a policy report entitled Primary Solutions for Primary Care that really goes into more detail about the role of RNs and RPNs, I believe, in the primary care sector.
Great. So we've had questions about reactions to the report. How have people been responding? And certainly what I can say is that we've had a very strong positive response from members, from peers, from system stakeholders who have really embraced the report, see its value, recognize that it is evidence-based. I think that out there, pardon me, you know, there have been others who have expressed some concerns, and certainly this is not unusual when RNAO really takes a forefront leading role in advancing bold system change ideas. So there is going to be diversity of reaction to that, but given that, again, as a professional association that is grounded in evidence and the need to ensure that patient safety and quality of care delivery are optimized as we are embarked or in the midst of the system transformation agenda, we really do have an obligation to bring these issues to the forefront. And again, I want to keep my response grounded in the context that we really have had very positive response from members and many of the other stakeholders and colleagues that we work with. Okay, well, seeing no other questions, I think we're going to wrap up a little bit early. But if you do have follow-up questions, by all means, feel free to connect with myself directly or Anastasia or Doris. We're more than happy to hear from you and to engage in a conversation. So on behalf of Anastasia, myself, and RNAO's president, Carol Timmings, we really do appreciate the time you've taken to be with us over what may be your lunch break, and really do encourage you to continue to stay involved and engaged as this work continues to unfold. So thank you very much, and hope you enjoy the rest of your day. Bye-bye.